So most of you will be managing patients either with intracranial hemorrhages or potentially with an intracranial hemorrhage, because most surgical firms will accept head injuries, and certainly if you do a neurosurgical firm, you will need to. So, when you think about what types of intracranial hemorrhage you might come across, the anatomy of different types, how that's going to affect your clinical presentation, and then the management and treatment of those ones. So, without further ado, get your iPads out, your phones, computer, on the phone to a friend, and get ready to pause the video and get your answers down. So how did you get on with that? Well, hopefully you got all the answers down. Before we go into that, just recap a little bit of the anatomy. You've got the various layers. So on the outside you've got the calvarial bone, then inside that you've got the dura mater, which is essentially periosteum in the outer layer of that. Below that you've got the arachnoid mater, and then on the surface of the brain itself you've got the pia mater. And remember where certain vessels sit. So the middle meningeal artery sits on the outside of the dura mater, the circle of Willis sits within that space between the arachnoid mater and the pia mater. Also remember that the dura mater is fixed to the bones because it's essentially periosteum at the suture lines. Let's go on and see how you got on with different types. Hopefully you've all seen some images like these from the internet, and you've got a list of 4 types of intracranial hemorrhage. Before we look at those in depth, to give you a useful way of trying to remember these, think of everything going from the outside to the in, then you won't miss any types, and you can apply that to lots of other different ways you're going to look from the anatomy. If you're looking through a laceration, think about from the skin through down to the bone what may or may not be there. Same with the skull, we're going to go from the outside to the in, and that's why we recap the anatomy in the previous slide. So following that theme, let's look at the extradural hemorrhage or hematoma first. So it's from an arterial bleed, usually associated with trauma, and therefore it's going to progress fairly quickly with it being arterial. You can have an episode of loss of consciousness when basically the brain is taking a blow to the side of the head and will go into like a shocked state, then a period of lucency when that shock state returns, and then a deterioration and the patient going into permanent unconsciousness as the intracranial pressure increases. Now it will be limited in the extent around the cranial cavity the hematoma will spread, because the dura is fixed to the bone at certain points with the periosteum at the suture lines. So it will be limited in its extent. So let's have a brief look at the skull to look at the extradural hematoma. Here, if we open the skull, we can actually see quite clearly the suture line which the dura mater is adherent to, being essentially the periosteum, so that limits the extent of the hematoma. But we can also see the groove that the middle meningeal artery has made in the parietal bone. So any blow to the side of the head can easily fracture the parietal bone and rupture that artery. So the next layer down will be between the dura and the arachnoid mater, so it's below the dura, as in subdural. The vessels which are bleeding here are the cortical veins which cross the subdural space. You can remember the clinical presentation of these being a slower, delayed presentation because the bleeding is slower. They may well still be associated with trauma, particularly a contra-Q type injury, and also there's a patient groups which are at increased risk if they've got a slightly smaller brain in a bigger box. And this is alcoholics, the elderly, and the very young, who are at risk of developing subdural hematomas. The hematoma can spread extensively throughout the subdural space because there's no fixing points of the subdural space apart from the falx cerebri in the midline. The next space is below the arachnoid mater, which is the subarachnoid space between the arachnoid and the pia mater. Remember, this space has CSF within it, the fluid surrounding the central nervous system. The bleeding tends to be from a ruptured malformation or aneurysm from the circle of Willis, and there's a classic prodromal phase, then like a thunderclap headache to the back of the head, with a rapid onset of severe pain and may be loss of consciousness. Because there's a bleed into the CSF, which is irritant, there may be signs of neck stiffness with meningism and stiffness of the neck. The bleeding may be controlled with radiological techniques with embolization and coils into the aneurysm. The last piece to talk about is the bleeding into the brain itself, with bleeding into the self, i.e. parenchymal bleeds, often from the cerebral vessels, and tends to be the role of the stroke physician who manages these, and may be combined with the radiologists who may embolize bleeds. So hopefully the types are pretty straightforward, and a good technique to, when you're recording your anatomy or recording something, try and do it as systematically as possible so you don't forget something. So in this case, we started from the outside and worked our way inwards. To recall, subdural often has a period of unconsciousness followed by a period of lucency and then deterioration and loss of consciousness. The subdural, you have a different patient group. It's extensive, slow bleed from one of those bridging veins. And a subarachnoid is often a malformation. You get a sudden bleed, often with a warning bleed as well. So how do we manage it? Well, you've got the ABC, and if it's a trauma situation, do it along ATLS guidelines. So you've got cervical spine control, a blow to the head, can easily have an associated neck injury at the same time. You scan the head, provided you've controlled the airway, and then refer to neurosurgery as appropriate. Essentially, they're going to make a decision: are they going to do a craniotomy or not? Do they need to decompress it? Do they need to evacuate it? Is that going to cause more harm than the hematoma itself, or is it progressing? And with the berry aneurysms, you may be discussing those with a neurosurgical radiologist as well. So hopefully that session's been useful. Let's see how we get on with the other ones. Cheers.